So always a pleasure to present folks in Michigan. My aunt still lives in Port Huron. I have cousins in Flint. I spent 1972 near Alpena. I spent a lot of time camping on Beaver Island, so Michigan has a lot of positive memories for me. May is Morel month in Michigan. I hope you had a good morel harvest. Also harvested blueberries in Michigan, so what a wonderful place. And today, I was asked to give you a bit of a summary of where we are with electronic health records and interoperability, where the next couple of years are going, and I thought it would be important to share a context. How did we get to where we are today, and what does that imply for the near future? So you guys are controlling my slides, so we go from the title slide to the first slide called A Brief History of Time. Now, I believe Dr. DeSalvo may be actually speaking with you today, and so remember, I've worked for 5 national coordinators, starting with Dr. David Brailer in 2004, up through Karen DeSalvo through 2016, and during that period of time, you've had 5 folks with 5 very different approaches to solving EHRs and interoperability problems. So David Brailer, if you remember, first national coordinator, had a budget of 0, and his 4 ideas, which are actually still pretty important today, we better move the healthcare system from a paper-based system to a digital system so that at least if the data is digital, we can do something with it. We should foster some kind of interoperability. We should be able to measure quality. We should be able to do some public health computations. And we should engage patients and families. So we think about that. Those 4 ideas have really been consistent through all 5 national coordinators. In fact, if you look at the current ONC multi-year strategic plan, those 4 ideas are still there. Now, Brailer was replaced by a fine gentleman, Rob Kolodner, and Rob, of course, did not have much of a budget either, and he was kind of a caretaker during a period of time where there wasn't really political will or a budget. And then David Blumenthal arrived and was given $31 billion, $2 billion in ONC directly and some $31 billion in stimulus, and created then the Meaningful Use program, and high-tech was implemented. And I think if you reflect on it, stage 1 of Meaningful Use was quite helpful. It elevated us all from those EHRs written by our brothers-in-law running in Fox Pro on DOS to some things that were capable of problemless management and medicationless management and use of basic standards. So the certification was pretty reasonable. I think the Meaningful Use criteria are pretty reasonable. David Blumenthal left, Farzad Mostashari joined, and his notion was the industry is moving too slow. So we need, through regulation, to kick them and to try to break through barriers. And so Meaningful Use Stage 2 was created, and the challenge with Stage 2 was it presupposed cultural change and infrastructure that didn't exist. So in effect, it was like, you must drive a car, and I'm going to penalize you for not driving a car, but there are no roads. And so it was fine to say we must use the direct protocol, but we didn't have a directory of doctors, so we had no idea how to reach anyone using that protocol. We didn't have consistent consent. Wasn't quite sure. Opt in, opt out. What do we share? How can we share it? How can we use it? We didn't have a master patient index. It wasn't really quite clear what patient we were referring to or where patient records might be found if you needed to pull them. So as I'll talk through in the next couple of slides, this enabling infrastructure is really what is so important to work on next. And Farzad tried, and, good guy, but I think what we saw was with Stage 2 Meaningful Use, doctors and hospitals didn't really meet the criteria in large numbers. And if they did it by checking boxes. I am going to send a bunch of data to a place. Now that data won't be useful, and in fact it won't be incorporated, but I can check a box that I did achieve a numerator. Not precisely the policy goal we wanted. And now Karen DeSalvo has been charged with turning the Meaningful Use program into some outcomes-based rather than process-based approach. And as you can see from CMS, we have these new regulations, the MACRA and MIPS, or Merit Incentive Pay System, that intends to offer a lot of flexibility. And, of course, the interesting challenge will be over the next several months, as those regulations are refined, will we see a set of regulations that give the vendor community the opportunity to innovate, give doctors choice as to what to implement, include specialists, behavioral health providers, long-term post-acute care providers, those who are not really included in previous programs. Still very much a work in progress, and I've written quite a lot about it. I think very important that we do not repeat the mistakes of meaningful use stage 2 by being overly prescriptive or presupposing magic will happen before infrastructure is there to support it. So that's a context of where the 5 national coordinators have brought us over the period 2004 to 2016. Now, what about interoperability? Well, some of you probably remember the early days of the wars between CCR and CCD. Is your XML better than my XML? We had in the HITSP days, and that was in the Bush administration, the first challenges of harmonizing standards. And remember, what harmony means is everyone leaves the room feeling equally good, as opposed to compromise, which means everyone leaves the room feeling equally disenfranchised and dissatisfied. So harmony across all the stakeholders, government and industry, providers and payers and patients, was somewhat hard to achieve. But in those early days, we did enumerate a few standards for vocabulary and content and security that laid a foundation for some of the protocols we're working on today. The HITSP organization was followed by, in the Obama administration, the HITC organization, HIT Standards Committee, which I co-chaired. And that took the next level of detail with the standards and did such things as created the Value Set Authority Center at the National Library of Medicine. So now you can download all the vocabularies you need for medications and problems and labs in a beautiful crosswalk that maps various vocabularies. And so we finally have, I think, done a pretty good job at ensuring that when you send a medication list from one place to another, that it's clear what those medications are. Or when you have a problem, that problem list is recorded consistently across different EHRs. It doesn't say high blood pressure, hypertension, and elevated blood pressure, 3 concepts which are identical in 3 different EHRs. So that's all good. Now the challenge, however, is that coming out of the Standards Committee, we still use the CCD and the CCDA, which, yeah, sort of fine in some respects. They are a summary of the care in XML. They're very straightforward to create, but very challenging to parse. And that's because there's too much optionality. You don't know exactly what data is there, what data is not, who has chosen to implement it in what way. So what we've seen is there's a need to eliminate optionality, simplify content standards, and hence the Argonaut Project. And for those of you who aren't familiar with the Argonaut Project, the idea was in 2014, AHRQ commissioned a super secret group of scientists called the Jasons to figure out how to fix healthcare IT. And the Jasons convened Facebook and Amazon and Google and a variety of stakeholders inside and outside healthcare and said every other industry has used JavaScript object notation, a very simple way using application program interfaces of connecting pieces and parts. Facebook add-ins, iPhone apps, they all are using a fairly similar approach, except healthcare, which uses this arcane XML. So the Jasons had recommended we move beyond that set of standards, and so wanting to follow the Jasons, a group of interested stakeholders created the Argonauts to go on a journey to slay the Gorgons, find the Golden Fleece, and achieve interoperability. And we have, over the course of the last year, introduced a set of open source, publicly available, for free guides to implement FHIR, the Fast Healthcare Interoperability Resources, with the hope that Epic and Cerner and Meditech and eClinicalWorks and Athena will use these less complex standards for the exchange of the meaningful use core data set of about 150 data elements. And they're making pretty good progress. we've certainly had a number of connect-a-thons. They have created running code, and in our community, we have been able to create these Argonaut APIs for creating some apps that read data from our various EHRs. So we're making some good progress there. Certainly not done. There are standards we still need to work on, like provider directory query, search for a patient record in the community, certainly some ways that we want to clean up and simplify security using OpenID and OAuth, again, standard techniques that pretty much every other industry has already adopted. When you go home and you go watch Game of Thrones on HBO, you are signing in through Verizon or RCN or some cable provider using OAuth to HBO to get your content. It's that similar idea of a chain of trust for simple authentication that we want to implement for interoperability. So hence, what the Argonaut project will continue to work on over the course of the next year. Now, we can't forget that the patients and their families are also a really important part of interoperability. So one way to connect data is to send it provider to provider, or from provider to registry, and then have it read by providers or government or other interested parties. But another way is send it to the patient. And the patient is then able to send it to wherever the patient wants it to go, applying privacy filters as are appropriate. I mean, we know consent is so challenging because if a medical record contains a problem list that has HIV, mental health, substance abuse, domestic violence, sexually transmitted disease, a patient may want to shape that problem list before it goes to the next provider of care, not changing it in any kind of way that would falsify their diagnoses, but maybe the patient has decided not to share substance abuse history with their dermatologist, and that's completely fine. And so hence this idea that patient engagement and patient-mediated electronic healthcare information exchange is probably pretty important. And you're going to see some interesting new technologies to make that possible. Now, next week on Monday, Tim Cook launches the Worldwide Developers Conference in San Francisco, and a variety of healthcare products will probably be described. Of course, you never quite know exactly with Apple what it is they're going to do. But Apple has this strategy of Health Kit, Research Kit, and Care Kit. The idea with Health Kit is you have on your device, your iPhone, all the data from all the devices in your home, your bathroom scale, your blood pressure cuff, your glucometer, could be pulse ox, sleep apnea monitor, whatever. You decide who to share it with, and then we build a connection of all the devices in your home to a care team or care provider, and that's all done through Health Kit. Research Kit, contribute your data to clinical trials or be involved with a set of researchers in some new therapies. And with Care Kit, a couple of things. The idea being pretty important to understand how you feel. What's your mood? Are there side effects? So in addition to objective data, gather subjective data. Be able to have a care plan, track progress against that care plan with a dashboard, and enable secure communications with your clinician. So just keep this in mind as you are thinking about your strategy for interoperability, community-based, provider-to-provider, registry, government, all good, but also think about these new enablers that potentially could be on every phone in the country that enable data to be sent directly to the phone and managed by the patient. As well, the patient can contribute their own healthcare data, objective and subjective, back to the record. So some pretty exciting developments. And I believe Samsung is working on similar type stuff, so it isn't just going to be Apple products. As we exchange more and more data, we do have a problem, and that is too much data and not enough wisdom. And what I mean by that is I have 4 petabytes of data in my data center. Giving access to all of my clinicians to 4 petabytes of data doesn't help them get through their day any better. what they need to understand is what are the events that are occurring in a patient's life? What are the actionable issues they have to address? So, for example, if a patient has 1,000 normal blood pressures, not interesting. But if suddenly their blood pressure drops or suddenly their blood pressure increases, that's something that's actionable, and a clinician should be notified about it. So our view of big data analytics and population health and care management is, sure, raise alerts and reminders where there are interval changes, but also present to the care team, the care traffic controllers, which are maybe some non-physician extenders. How is the patient doing with regard to a disease state based on a guideline? Where is their variance? Where do there need to be appointments scheduled? Where do there need to be follow-ups done, home visits, telemedicine, etc.? And that's really true wisdom, which is let's focus on the wellness of the patient in their home based on enrolling them in a care pathway or plan and then ensuring they're following that care pathway or plan. That, again, is going to take some data from the patient, and hence this idea of potentially using not only the EHR and its population health features, but CareKit and some of the patient-facing features to build a closed loop of care management with big data analytics. Now, cloud and mobile, I want to just talk about that briefly. That what I find is more and more doctors are wanting agile EHRs, the ability to get new features and functions without paying a lot of money or waiting for a lengthy upgrade process. So the idea that a cloud-based, web-accessible or mobile-accessible EHR is continuously updated and continuously gives the clinician new features on a subscription basis without having to buy licensed software or keep servers running, etc. It's pretty attractive. So I am starting to see a lot of cloud offerings. In our area, of course, Athena, cloud-hosted EHR, ECW offers a cloud, Meditech now offers a cloud, Epic is building a cloud, Cerner has a cloud. So I think you're going to see more and more of a migration to the EHR and interoperability with the EHR as a cloud-hosted service. You're even seeing players like Amazon get into the business of offering cloud hosting services for healthcare, and they will sign a business associate agreement and ensure privacy is protected. So some interesting big changes as I talk about what I said are the foundations, a set of policies that will move us to outcomes, a set of standards that are easier, a set of patient and family engagement and big data tools that include more parties, as well as now new technologies, cloud and mobile, that will make it easier to deploy. So if that's the foundation, I think it's important that we take a look at how we've done. Because in the next two slides, I reflect on how we've done as well as our grades, because it's not all rosy out there. I think we have to be very, very careful. What you've seen is we have created EHRs in doctors' offices. We have created automated workflows where there was paper. And yet we have created a nightmare where clinicians are working 20-hour days after the end of their clinic visit, go home, have dinner, and spend several hours creating documentation. There's 140 data elements needed as part of the Meaningful Use program for every encounter. And the clinicians are finding endless checkboxes and pull-downs and clicks to get those 140 data elements in. And in fact, many are saying, I can't function at the top of my license. I'm seeing fewer patients. I'm doing less cognitive work. I'm doing more administrative and clerical work. So that's not exactly a perfect outcome. Just to make sure that we're on the slide that says assessing our progress. So EHR, safety, quality, efficiency, maybe we have done some good work in reducing some error. But again, usability, not so great. Physician satisfaction, really pretty poor. And interoperability is a little hard to define, although we are shipping more and more transactions to public health than ever before and passing off summaries of care to next providers of care, doing labs electronically more than ever before. Is it always the case that we have the data that we need about the patient from every site of care when we need it? And that's not exactly true. So yes, certainly there's still work to do in that regard. And although we have got view, download, transmit, and the ability, in theory, for patients to get their electronic summaries, you look at the numbers of patients doing it, it's clear it's not easy enough. And typically, remember that in stage 2, we had a 5% criteria for patients looking at their records and engaging in secure communications, and that had to be modified to one patient. One guy looks up their record. One guy does secure email, because we weren't seeing the numbers of patients engaging that was anticipated. So clearly work to do. Again, this mobile phone app that makes it easy, probably a good next step. Do we have all the tools we need to deliver value-based purchasing to ensure we're doing the right thing at the right time at the lowest cost with patient preferences kept in mind? Not quite there yet. Most big data analytic tools I see at HIMSS are compiled in PowerPoint, which is a very impressive development language, so easy to change. And are we seeing as much mobile technology as we should in the industry? It isn't exactly true that our EHR vendors are running native mobile apps for many of their products, and Citrix is not a mobile app. Try using Citrix on an iPad, not a pleasing experience. So on the next slide, you see our grades. I think we really have to say we have not yet created the EHR usability or physician friendliness we need. So we're probably at a C+. We probably have not created the interoperability as defined as the data that a clinician needs to make decisions at the point they need it the majority of the time. We have done some work, as I've said, on patient-family engagement, still not easy enough. Done some analytics, but still not quite turning the data into wisdom yet. And we haven't, as I said, quite deployed mobile. So you can see C+, C+, B, B, and B. So we're probably at about a B- for the $35 billion that we've spent so far. So let's go to the next slide, and let me illustrate how we can do better. So my wife, a few weeks ago, came to me and said, I have an unexpected weight loss, my heart rate is 110, my eyebrow hair is thinning, and I'm feeling fatigued all the time. Now, for the doctors in the room, I've just described hyperthyroidism. So what my wife did was picked up her iPhone, and with her iPhone, she then messages securely her clinician to say, I believe I have hyperthyroidism based on these symptoms. I believe that we should probably do some lab testing. And the clinician says, yes, in fact, you need a TSH, a T3, a T4. I've just ordered that electronically at the Quest near your home. So just go 2 miles down the road, get your blood drawn, we'll see what you got. The lab results come back. My wife was able, through a Quest app, to get access to her results as soon as they came back. Her TSH was 0, her T3, T4 off the charts. She had hyperthyroidism. Messages her doctor. They agree to get a referral to a specialist. Specialist happens to have an appointment the next day in a suburban location near our home. She goes and visits the specialist. One more lab test is done, a thyroid-stimulating immunoglobulin to see if she has Graves' disease, comes back positive. My wife has full access to the results, clear that she has Graves' disease, has the discussion with a specialist, radiation ablation of the thyroid surgery, or a medication, methimazole. They decide on methimazole. It's e-prescribed and shows up at the pharmacy, a Walgreens, which is 50 feet from our home. So think about the transactions I've just described to you. I mean, all the technology to do that interoperability exists today. And many of the apps exist today. It's just not common practice. That's the kind of, I think, clinical service each of us would like. It was efficient. It was cost-effective. It was rapid. And today, my wife has a totally normal TSH, T3, T4. She's completely fine. All is well. So that's really, as we think of use cases, the kind of end result we're all trying to achieve. Now again, there are still problems with interoperability. So for example, although it's true we can pull medication lists from SureScripts, We can see a fill history, what was reimbursed. It isn't quite perfect because it isn't an accurate medication list as to what you are taking and how you are taking it. So in the case of my mom, when she broke her hip, she went to an emergency department. Emergency department, of course, tried to reconcile all her medications, look at everything she had ever been prescribed since 1982, put her on 22 different medications, and when I got to see her in Los Angeles, she was a mumbling, incoherent mess on a whole variety of mind-altering meds. Now, probably interoperability of a medication list from the primary care doctor's office 2 miles away would have been a better way than looking at a fill history from pharmaceutical claims transactions. So still work to do on being able to query that local doctor's office. I was recently diagnosed with essential hypertension, and I was able to use my phone to gather data from a Withings blood pressure cuff, send that electronically into the EHR at Beth Israel Deaconess, where my primary care clinician was able to understand that my blood pressure was not related to time of day, stressful life events, caffeine, or anything of that nature. That truly it was just familial, and it was treated. And all that done with mobile devices and simple interoperability with patient-generated healthcare data going from device to phone to EHR. My wife was diagnosed with stage 3A breast cancer in December of 2011, and what we did at that time was we looked at the 17 Harvard hospitals' data sets of cancer patients like her, all anonymized, all aggregated, but it gave us the capacity to understand what potential morbidity and mortality she might encounter and what treatments were likely to be effective. Again, as we think of the future that we want, we should be able to mine the data of patients who've come before us so that we can understand how patients in the future may best be treated. And this technology, again, it completely exists. So much of it is about politics and trust. The technology we used is called I2B2, available for free, downloadable at i2b2.org, and 60 universities, including University of Michigan, Ann Arbor, have already implemented this software. So the idea of querying data sets across organizations to build a learning healthcare system already exists. And I think, we will see that increasingly our cloud vendors will figure out some of the challenges of indemnification. And what do I mean? Although it's true that Amazon will sign a business associate agreement and protect the privacy of the data and won't do advertising or mining or reuse or sale of the data, what if, through the fault of Amazon, there is a privacy breach? As you may know, the average cost of dealing with a privacy breach in healthcare is today about $300 per record breached. So will Amazon sign a contract that says, oh yeah, we'll pay you $3 million if it should be the case that your records are breached? They won't. So what I think we're finding is you have to buy cyber liability insurance yourself in order to protect against the risks. Although you'll sign all these legal agreements, really, if there is a breach, the cost of notification to patients, buying credit monitoring services if necessary, dealing with fines and forensics really does sit on the covered entity. So probably best to calculate how many patients do you have, multiply by $300, and buy at least that much cyber liability insurance. So here's where I'm going to get a little bit controversial, because I know you probably have many speakers today, and many of them won't agree with me. But I truly believe meaningful use has done a wonderful job getting us to where we are, but it has run its course. Talk to doctors and hospitals about how they are able to tolerate a next stage of meaningful use. And what they'll tell you is they are burned out. They are broken. They are no longer able to get through their day. They would be willing to consider pay for quality, value-based purchasing, approaches that give clinicians the flexibility of achieving a result however they want to achieve it. So that is, if your goal is reducing readmissions, and you decide you're going to buy Withings bathroom scales for all your congestive heart failure patients, and you're going to look for weight gain of 10 pounds in a weekend, and if there is such weight gain, that you will then do a visiting nurse or telemedicine visit to double their Lasix, and you're going to keep them out of the hospital that way. Well, great. Go for it. If, on the other hand, you want to hire high school students with clipboards to go into the homes of the elderly and find all high-sodium foods and get rid of them, go for that too. I mean, again, if the outcome is reduction in admission because congestive heart failure patients eat too much sodium, have weight gain, and then come to the hospital, solve it as you will, as opposed to requiring 20 new data elements to be typed in on every patient and a whole variety of process measures, because process doesn't necessarily equal outcome. So let's declare victory on meaningful use, move forward to an outcomes-based approach, give vendors and give clinicians and hospitals freedom to choose how to achieve an outcome. Certification, I find, is something that has also run its course. Early certification was good. Does your EHR have a problem list, a medication list, an allergy list, the capacity to have electronic labs? That's all okay. But what we have now achieved is a level of certification criteria so burdensome that the EHR vendors are going to take 2 or 3 years to deal with all the certification criteria. If you look at the 1,500 pages of the 2015 certification rule, it contains vast amount of certification criteria that have nothing to do with the meaningful use program. And so you're finding vendors saying, I know I really only have to build those pieces that are specific to meaningful use. Oh, but now we got MIPS and MACRA. Now I have to do this and that. And so suddenly the entire innovation agenda of the private sector has been co-opted by the certification rule, and their customer requests, business imperatives, the things they would like to do to take us to the next level of usability, they can't, because they have devoted 100% of their developer time to just dealing with the certification rule and compliance with it. So really need to rethink that whole concept of certification, yet focus on outcomes and offer some flexibility. You often hear folks in Washington talk about this idea called information blocking. Again, controversial statement from me. I have never seen it. It is like the Loch Ness Monster, often talked about but rarely photographed. So I have never seen a volitional provider organization or vendor organization prevent the exchange of data where there's technology available, will to do it, and a business case. I just don't see that there are real issues with the EHR vendors being evil. And I really think that, Congress has been told that's just not true. What we need are certain technology enablers that you've already heard me talk about. A national provider identifier so we can match up patients, a provider directory, a trust fabric, rational consent and consistent laws and governance. And if you put those things in place, the existence technology would function and we would have much more information flow. I mean, in Massachusetts, we're already shipping 10 million transactions a month, and it's because the state has chosen to build all those things. And I'm sure in Michigan you either have built them or are working on them. So let's get beyond information blocking and let's focus on those true enablers that are going to really facilitate information exchange. Along the way, we must reduce clinician burden. We do not want clinicians to be clerks spending 50% of their day entering data or trying to figure out interoperability. We need a workflow and usability that is team-based. So we have clerks and nurses and pharmacists and social workers and doctors all working together to keep patients healthy. If we can really think through the future EHR as not just a dumb data capture system, but a workflow tool that brings a group together, including patients and families, I think we'll have a much better result for all. And the way we can achieve that is to return innovation to the private sector. Government has had a very valuable role over the last several years, but now it's time for government to give us some outcomes and let the private sector innovate and not have another tranche of prescriptive, certification, or meaningful use type rules. That, I think, will get us to a much better state and where we need to be. I think that provider organizations are going to do their very best to innovate, but they also will be in some ways co-opted by regulatory compliance. So if we free the private sector to innovate, I think the next 5 years may very well belong to unique products and services coming from startups that we've never heard of before, or from unusual places like Apple, Google, and Amazon. So I do feel quite positive. I'm not sure who the next president will be. Wouldn't want to make a political statement about that, because it always gets me in trouble. But if we do imagine that government takes a lesser role and the private sector moves us forward, in some ways, that future-proofs us against whatever presidential election nuttiness may transpire. Well, folks, I did want to leave a couple of minutes for questions, and I hope that there's ways on this WebEx that we can relay a couple of questions from you, and then I can give you answers. So let me turn it back to you.
Thank you for your statements. Really appreciated the statement that you made regarding process does not equal outcome improvements. I had a friendly amendment. You followed it up with let's have providers and hospitals decide how to realize outcomes, and the friendly amendment is to include the family caregiver and the patient as well.
Absolutely, that's true. Yeah. And sorry I did not make that clearer, but as I was saying, with the care kits and the patient-generated healthcare data, you can't achieve that outcome without the participation of the carers in the home and the patients themselves.
Is there another question? David, I have a question if you'll ask. Well, we got one over. Okay, get the local ones first, yeah.
Dr. Halamka, thanks for your remarks. Is the U.S. and the governance frameworks that we are developing, is that the world leader so far, or are there other international models or places we should also look to?
Well, sure. So I travel the world, and so I have seen many healthcare systems in many international locations, and their approach to interoperability is quite different from ours. And understandably. So, for example, take a look at Scotland. How many people in Scotland? 5 million. How many PACS systems in Scotland? 1. Why would you need more than one PACS system if you only have 5 million people? So hence, what Scotland's done is created an image repository for the entire country that every clinician can view, and hence there's no issue of interoperability because they only have one repository. Or in the case of Sweden. Sweden has a very interesting culture. The notion among the Swedish is healthcare is provided to you by society. So it in fact is, one, your moral responsibility to stay healthy. So don't supersize your lunch, but it's also your responsibility to share your data. So although in the U.S., with our 330 million people, we have quite heterogeneous privacy ideas, I want to share everything, I want to share nothing, I want to share everything but my mental health, etc. In Sweden, they really just don't have that cultural issue. It's, I want to give all my data to all my caregivers so that I can get good quality coordinated care. So consent is just much easier. And Sweden also has a national provider and national patient directory system. So it's much easier to share data across providers and to understand which patients you're talking about. Because at birth, everyone's given a number. So, let's look to Scandinavia. Let's look to some aspects of what the UK has done. Again, not everyone's perfect. Certainly the U.S. is more advanced in many aspects of its EHRs, especially EHRs in hospitals, but other countries with smaller populations have gotten beyond some of the policy barriers and really tried to achieve data liquidity by creating a cultural imperative to have it.
I have one you can ask for me if you want to just use the phone. And the question is, in banking and a lot of other industries, interoperability has a lot of legal documentation beyond what we have for a business associate agreement. You're not going to be able to relay that? All right. Hi, Dr. Halamka. This is Tim Pletcher. Thank you again for a good presentation. My question is, a lot of other industries that have achieved interoperability, people often point to banking. There's a pretty significant infrastructure for sort of legal bilateral agreements for what's going to happen in lots of situations. We have lots of technical implementation guides and technical standards. Where do you think we are on really defining a lot of those sort of nitty-gritty bilateral legal agreements over and above a business associate agreement?
So that is a brilliant point. And so in Massachusetts, again, we chose to do this. Every state does something different. We created a single uniform participation agreement for every provider in the Commonwealth and made it such that it's transitive and that you don't have to have bilateral agreements of every person with every person. I mean, that's an N-squared problem. What you have is more of a hub and spoke idea. State government is the curator of a participation agreement. Each provider organization signs a participation agreement, and then data can flow from provider organization to provider organization using that trust fabric. So hence, I think you're exactly correct that we've taken our standards forward. We've started in some locations to build enabling infrastructure, but unless you have participation agreements and a trust fabric, all the technology in the world is not going to help you. And certainly a state government or state organization like yours can be a great convener and facilitator for all that participation agreement and governance activity.
Do we have any other questions?
Well, I understand that was the last question. So,
Okay.
Of course, again, always happy to speak with you folk. And I do live by email. So if there are things that come up, especially controversies after other speakers totally disagree with me, feel free to let me know, and I will be happy to respond.
Thank you.